This is a Pokeball. But we're not talking about that today. Because today is Brain Tumors Part 2. So the critical thing to think about with this group of tumors that we're talking about is that they're not cancer. Don't tell. These tumors are abnormal growths, yes. Cancer, no. So you're still going to see terms like OMA, which means growth, but cancer is defined by its ability to metastasize, spread other places in the body. This stuff is going to stay in one spot for the most part. Let's take meningioma. Meningioma. Hey, break apart the term. Meningioma. 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 A benign growth of the meninges. Just like a true cancer, a meningioma, even though it's not cancer, it's a benign tumor, does involve your typical cancer genetic alterations. So in that setting, think about that delicate balance between oncogenes and tumor suppressor genes, because the story is basically the same. You throw out one or more of those genes on both sides of the equation, growth and division fall out of balance in favor of abnormal cell growth. For meningiomas, commonly affected oncogenetic pathways include the mammalian target of rapamycin and PI3K. mTOR and PI3K are two common growth and cell signaling pathways that become unchecked and are allowed to drive cell reproduction and division in both benign tumors and metastatic cancers. So you might wonder, well, what offsets the balance here? What offsets the balance between oncogenes and tumor suppressor genes for meningioma or any other benign tumor or cancer? Well, think about things that potentially damage cells and damage cells' DNA. For example, exposure to radiation. There are actually some hereditary cancer syndromes that we're going to talk about in a few minutes, one of which is neurofibromatosis, that can also put people at risk for the development of benign tumors as well. Meningiomas are one of them. Did you know that meningiomas are 2 times more common in the ladies? That's one of those things that's epidemiological. We have that data. We're not exactly certain why that is, though. Another thing that's kind of interesting about meningioma, at least I think, is that a lot of times they're actually asymptomatic. I can't count how many patients I have worked with that had workups that included brain or cranial imaging, and the meningioma was found incidentally. The person really didn't have any other signs or symptoms. That being the case, if the person is symptomatic, the most common thing is a headache or something local related to the mass effect on the tumor. Thankfully, these can be surgically removed, and for the most part, you're done. Here's something that a lot of you probably won't come across all that often because it just isn't that common. But it's worth briefly mentioning here so at least you know what it is. An acoustic neuroma, also called a vestibular schwannoma. You just love saying that. Schwannoma. Schwannoma. A benign tumor of cranial nerve 8. Basic pathology is the same as a meningioma, and again, basically the same as all cancers in general. For purposes of this class, I want you to think of abnormal growth in the body as a disruption between oncogenes and tumor suppressor genes and that delicate balance that exists between them. The Neurofibromatosis 2 tumor suppressor gene is thought to be more commonly implicated in acoustic neuromas, but because they're not that common, there isn't a whole heck of a lot of research on them. The most common place that these occur is in the branches of the vestibular nerve that you can see here circled in red. When symptoms are present, the clinical presentation of acoustic neuromas has to do with cranial nerve 8, things like loss of hearing, tinnitus, which is a ringing in the ear. Oh man, that Guns N' Roses concert really did me in. Almost every time I give a brain tumor talk, somebody raises their hand and goes, "Can cell phones cause brain tumors?" They don't actually sound like that. There's been a very interesting debate for quite a few years with regard to cellular telephone use and the development of cancer. Brain tumors most commonly, but there have been questions with regard to other types of cancers as well. Most of the worry lies in the fact that cell phones and other radio frequency devices emit radiation. How many of you have actually read your little those little things that come with your iPhone or your Samsung? There's always a little blurb in there. Usually it's under FCC compliance laws that does say that it's a radio frequency emitting device, and there's usually a warning alongside of it that says do not hold it directly against your body. That's to reduce your exposure to the microwave radiation that these devices emit. I will tell you that the debate on whether or not cell phones and radio frequency emitting technology causes cancer is ongoing, and we don't have anything definitive yet. But if it's an area that you're interested in, there's lots of research already occurring. I would refer you to the biggest trial yet. It's called Interphone. Go to the library, search it up in the search bar, and you'll find quite a few studies already on the Interphone trial. Pituitary adenomas. Now, pituitary adenomas are benign tumors of the pituitary gland. But here's what makes them a little bit more challenging. They're more common than things such as acoustic neuromas. They're benign. They can be removed by going through the nose and up into the brain and snipping them out. But when you think about the basic pathology and then connect it to what the clinical manifestations as a byproduct of that pathology are, what you have to remember from A&P are the hormones produced by the anterior pituitary gland. And that's where things can be a little bit challenging. I don't know if A&P taught you the acronym FLAGPET for your anterior pituitary hormones. I like it. If you have something else, that's great. But let me tell you this. In summary, when patients have a pituitary adenoma, they can present with hyperpituitarism or hypopituitarism, depending on whether the tumor cells are secreting pituitary hormones or they are not. Let that sink in for a second. If those tumor cells that are growing and dividing and growing and dividing are hormone secreting tumor cells, you'll have hyperpituitarism. If those cells are not, you'll have hypo, because the growing mass will actually start suppressing growth and secretion of normal pituitary hormones. To make it one step more complicated and one step more fun to think about, depending on where the cells of growth occur is what depends or what initially presents as the tumor. For example, a tumor that secretes growth hormone can cause gigantism or acromegaly, or both, depending on how long it goes on. That tumor is secreting extra growth hormone, and the person's body is subject to that. So for pituitary adenomas, the most important thing I could tell anybody is this. Ask yourself, is the cells from which the adenoma came from, are those cells secreting hormones? If so, which one or ones? And if they are not, suspect hypopituitarism. Angiomas are literally just tumors of blood vessels. Angio, blood vessel, oma, growth. You may hear them under other names, for example, arteriovenous malformation, but basically the idea is the same. There was some offset balance, again, between growth genes and genes that stop growth, and the result was an angioma. Some people are born with these. When they occur in the head, they can be especially dangerous because what if they rupture? You could have a bleeding hemorrhagic stroke on your hands. Thankfully, angiomas are benign. Once they're discovered, they can be removed surgically. Angiomas encased inside the skull can produce some symptoms. The symptoms are not very specific, but include things like headache and seizures, focal neurologic deficits. What that means is that if the growth is pushing on a very particular part of the brain, the person may exhibit a very particular neurologic symptom based on what part of the brain is affected. More broadly and more perhaps dangerously, hemorrhagic stroke in the event that these things rupture. There's two different versions of the neurofibromatosis pathology. We're going to talk about number one. NF1 is a tumor suppressor gene that produces a tumor suppressor protein. In NF1, that protein is unable to do its job in controlling a very particular cell signaling growth pathway called the RAS cell signaling pathway. The NF1 gene sits on chromosome 17, and this is inherited in an autosomal dominant fashion. So I've included here a small genogram displaying how the pattern of inheritance works for this particular ailment, or for basically any ailment that is autosomal dominant in nature. And remember that when we use the word dominant versus recessivity, what we're talking about is the expression of a gene or an allele as it would compare to the other allele that the person has. Now, the clinical presentation for neurofibromatosis 1 is unforgettable. Once you take care of one of these patients, you'll never forget it because they get these benign skin tags all over the place. And you don't forget it. Unfortunately, this is a germline genetic condition. And by germline, I mean that the disorder to NF1 is present in every cell in the body. So what that means then is that every cell in the body whose phenotype requires NF1's protein, there may be affected tissues in many, many parts of the body. Whatever tissues in those parts of the body that require or utilize NF1 regularly. That's why under complications we have all of these potential complications. Soft tissue sarcomas, central nervous system tumors, neurofibrosarcoma, which is basically the malignant version of neurofibromatosis, rhabdomyosarcoma, gastrointestinal stromal tumors. With this one condition and this one gene not able to produce its tumor suppressor function in a cell, all cells that utilize that gene as part of their phenotype present areas of tissue, cellular tissue, at risk for the development of complications and many other cancers down the road. Li-Fraumeni is another germline mutation inherited from parents and inherited in an autosomal dominant fashion. The error here is also on chromosome 17, similar to neurofibromatosis, but in this case it has to do with the gene that codes for the p53 protein. p53 is the most widely used tumor suppressor gene and protein in our bodies. Its nickname is the guardian of the genome. It has a lot of cellular functions. In that regard, people with germline mutations to p53 have a condition called Li-Fraumeni, and they are at risk for many cancers over their lifetime. In addition, they get cancer early earlier than the average population. Cancer incidence goes up naturally as we age in people with germline mutations such as neurofibromatosis or Li-Fraumeni or von Hippel-Lindau. Those types of genes that you were born with put you at risk for cancer at an earlier age than would be seen in the regular population. Von Hippel-Lindau disease is just like neurofibromatosis, just like Li-Fraumeni. It is yet another germline mutation to a tumor suppressor gene, this one on chromosome 3, the VHL gene, the von Hippel-Lindau. Just like neurofibromatosis, just like Li-Fraumeni, these people are at risk for multiple cancers, including cancer in the brain, and they're at risk for those cancers earlier in life than the normal population would be. Before we end this section on brain cancer and brain tumors in general, this is probably a good time to insert just a little bit of thought and words with regard to increased intracranial pressure. I need to remind you that the skull is enclosed in space and that it can't handle growth of masses or a lot of edema. Because what happens is, as things are growing inside the skull, and again, it's a fixed cavity, other stuff starts getting kind of squished. I don't know if you do this or not, but brain tissue is spongy. So, for example, as a brain tumor is growing bigger and bigger in size, a lot of times it's displacing the brain. Sometimes that displacement can actually push on cerebral blood vessels and block blood flow. The clinical term that you'll hear over and over again for this is mass effect. What kind of effect is our growing mass having on this closed cavity that is our brain? Now, brain tumors aren't the only thing that can cause increased intracranial pressure. For example, central nervous system infections, such as meningitis, can produce collections of inflammatory fluid that also cause increased intracranial pressure and start squishing things around. A stroke can cause a bleed into the brain that can have mass effect on brain tissue itself. Increased intracranial pressure, though, presents a particular clinical problem in that once the brain is getting all pushed around, sometimes when the mass is relieved, it recovers easily. Sometimes things get pretty serious. One of the most serious complications of increased intracranial pressure is downward displacement of the brain, specifically the brain stem, down through the foramen magnum and into the spinal column. When this happens, there are some very specific clinical signs that you guys that are going to go work in ICU need to know about. As brainstem herniation starts, changes to heart rate, such as bradycardia, changes to respiratory rate, such as dyspnea or bradypnea, just breathing slower, start to be seen clinically as that brainstem gets pushed downward and downward more further. Interestingly enough, we do have a compensatory mechanism that you ICU nurses will see clinically, and that is vasoconstriction body-wide, raising blood pressure to try to perfuse the brain better. Those three things, the bradycardia, the dyspnea, and the compensatory hypertension, are referred to clinically as Cushing's triad. We will mention Dr. Harvey Cushing a couple different times because he's kind of a titan in the world of medicine, and he lent his name to a heck of a lot of stuff. Thank you, Dr. Harvey.